welcome everyone. Really excited to welcome you to today's webinar, From Dispensing to Direct Care, the Future of Pharmacy Practice. Thank you so much for joining us today. So I'm Pooja Babara, the Executive Vice President of Strategy and Industry Alignment at NCPDP, and I'm introducing today's webinar as your host. And I'm really thrilled to bring you just this really special extended 90-minute webinar panel presentation. We've got a lot to cover and a great panel, but just some quick housekeeping reminders. All lines are muted to reduce background noise for our speakers. You can ask questions at any time via the Q&A box on your screen, and we will have a dedicated Q&A time with the panelists at the end of their discussion. So make sure you start to add your questions in, and then a replay of the video will be sent to all registrants within 5 business days. So before we get started, just going to take 2 minutes. Again, thank you to all our members in attendance. And if this is your first time joining an NCPDP webinar, we want to welcome you. NCPDP is a not-for-profit ANSI accredited standards development organization, and we really provide a forum for diverse membership focused on healthcare and pharmacy business solutions to move interoperability forward. Our standards have been named in federal legislation, including HIPAA, M.B.A, HITAC, and meaningful use. And I'm excited to share, many of you may not know, but this past year, our Board of Trustees undertook an initiative to update our 3-year strategic plan. And I'm really excited to just spend a minute or two on some of our new initiatives that we're focused on. But first, let's start with our vision. Our vision at NCPDP is to transform healthcare through connected care. And with our strategic plan, we're focused on leading initiatives to help meet this vision. And these are to improve data exchange, collaboration and innovation, and organizational excellence and sustainability. And we really address healthcare industry challenges through our standards-based solutions. And really specifically solutions that enable pharmacists to collaborate in new ways with other healthcare providers to close gaps in care and improve coordination of care. So we're thrilled to be able to kind of have this new 3-year vision and to support really all the great work that you're going to hear about from our panelists very shortly. So NCPDP strategic initiatives and impact pharmacy directly by improving healthcare access, quality, and safety. So again, I'm thrilled to be able to kind of introduce this panel. I'm going to be turning it over to our moderator today, my colleague, Stephen Mullenix. And joining us today are really 4 well-known and respected pharmacy association leaders to talk about a lot of the national efforts to integrate pharmacists into clinical care teams, to expand clinical and pharmacy and primary care services, and to gain insights into the unified efforts for provider status, standardized pharmacist contributions, overcome obstacles that remain to really bring pharmacists into a broader role in healthcare and much more. So with that, I'd like to introduce our panel moderator, Steve Mullenix. Steve is a colleague of mine, has really been an integral contributor to healthcare and the advancement of practice for many, many years. He joined NCPDP in 2009 and currently serves as Executive Vice President of Public Policy and Professional Industry Relations. Steve is an active member of numerous state and national pharmacy organizations, including NCPA, the Academy of Managed Care Pharmacy, AMCP, NACDS, and ASHP. So Steve, welcome, and we look forward to this webinar.
Well, thank you, Pooja. It looks like you gave the Cliff's Notes versions because I think I'm a member of about 10 other organizations, so including APhA, of course. So, but thank you again, Pooja, and thanks to our audience for participating in our NCPDP CEO webinar entitled "From Dispensing to Direct Care, the Future of Pharmacy." And I would probably go on to say that it's not the future, it's currently happening as well. But that said, we're hoping that it becomes more prevalent in the very near future. Again, my name is Steve Mullenix, Executive Vice President of Public Policy and Professional Industry Relations, and I'll serve as your moderator. With us today, you heard that we have four executives from four very significant national professional pharmacy organizations. You may recall that we held a similar program about 2 years ago that included three of the four individuals here today. Those being Michael Hogue from APhA, Doug Hoey from NCPA, and Casey Thompson from ASHP. We've added our good friend Chad Wertz from ASCP, the American Society of Consultant Pharmacists, because our viewers are very interested in the unique needs and activities around the long-term and post-acute care space. And so we have Chad with us today to provide us with that perspective. So again, sort of the cadence of today will be over the next almost 90 minutes. We will do some brief introductions. We will go into a series of questions in which all four of our panelists will have an opportunity to respond. And then we'll ask for some final comments from each of them. And then at the end, assuming we have time, we will have some Q&A. So again, submit your questions during that time. We have a team of individuals sort of organizing those for the Q&A portion of the session. So with that, and in the interest of time, let's go ahead and allow our panelists to introduce themselves, and we'll just go across the board here with Doug leading it off.
Thank you, Steve, and thanks to NCPDP for the invitation again this year. I'm Doug Hoey. I'm the CEO for NCPA. I'm a pharmacist and have been at NCPA for quite a number of years. NCPA represents independently owned pharmacies. That includes a number of regional chains as well as the quote-unquote mom and pop pharmacies. Our calling card is advocacy, but we also do training, education, and CPSN is a big part of our strategy. And I would be remiss to say that our current board chair, NCPA board chair, is Christian Tadros, who was the immediate past chair for NCPDP. So a lot of NCPDP knowledge, well, I don't know if a lot, but some of it's seeping into my head just from osmosis from Christian because of his vast knowledge. Again, great to be here.
Michael?
Thanks, Steve. Michael Hogue. I'm the CEO of the American Pharmacists Association. It's a pleasure to be with you, and I appreciate the invitation to be here. APhA was founded in 1852, one of the oldest professional societies in America, and we represent individual pharmacists from every practice setting, and even pharmacists who are not in practice but support the industry and support healthcare in lots of different ways. And the roughly 340,000 pharmacists and 400,000 pharmacy technicians and 30,000 plus pharmacy students could all find their home at APhA. And just to say also, APhA does a lot of advocacy work based in DC. But APhA also works very collaboratively with all the other associations on a number of initiatives and projects, and we find that it's always great when we can work together in ways like we're going to be talking about today. The last thing I'll mention is that APhA is home to two LLCs. One is Pharmacy Profiles, which we may talk a little bit about later, which is a credentialing company to help pharmacists be credentialed with health plans. And we also own a company called Health Shifts that's designed to change the way pharmacists and employers engage with each other to try to improve workplace conditions and the workforce. And those are important components of APhA structure as well.
Great. Casey?
Hello, everybody. I'm Casey Thompson. I'm Chief Operating Officer at the American Society of Health System Pharmacists. We just go by ASHP these days. We represent pharmacists that work in hospitals and health systems, which when I started over 25 years ago now, it generally meant acute care. Now it sort of spans the full spectrum of care given the mass amount of consolidation in the industry. So, from the bedside to the clinic, to the community, to the home, it reflects where our members practice in a variety of healthcare settings. I was pleased to see as I looked at all of our pictures that when we came on screen, we almost all look like those pictures. So they're all fairly recent. I still own that tie, and it's nice to see everybody. Look forward to the discussion.
Thanks, Casey. Chad.
I'm Chad Wurz. I'm the Chief Executive Officer for the American Society of Consultant Pharmacists, and like ASHP, we go by ASCP these days. Our membership spans 56 years. ASCP basically and likely started as a result of nursing home nurses consulting their local pharmacist on how do I take care of older adults in these, at the time in the late 60s, new congregate care settings that we call nursing homes. And over that 56 years, we've evolved really along two planes. One is the storage, handling, delivery, and procedures around providing medications in nursing home settings, assisted living settings, and then also individually, how do we take care of people that are on 8, 10, 12 routine medications for both older adults and the medically complex. So our pharmacists do those things. I like to think that our healthcare system right now is really at a point where pharmacists are becoming central to good quality care. We are at the busiest intersection, and that is a growing older adult population and a high utilization of prescription meds, and that puts pharmacists in a good place.
Great. Thank you, Chad, and thanks to the other panelists for that nice introductions. Let's move right into our first question. And question number one is a bit of a follow-up question from our 2023 session. When we met in 2023, you shared, three of you at least, shared what you thought were the biggest opportunities for a shift to pharmacist-provided clinical, or what we often refer to as primary care services. Do you see it the same way today as you sort of thought about that 2 years ago? And if not, what do you see as today's biggest opportunity or opportunities in the plural? And we'll start with Doug Hoey. Doug, you want to weigh in first?
Yeah, thanks, Steve. So if I had blipped, like from the Avengers in 2023 and came back in 2025, I think foundationally I would recognize a lot of things, but I'd also be like, what happened? There's so many different changes that have taken place in such a short amount of time in just 2 years. I think, again, foundationally, that the same foundation is still in place, which is, I think in 23, I talked about a public health need. We were coming out of COVID in 23, and we were really, I think one of the points I made was that COVID was a perfect storm, or awful storm, but a perfect storm in many regards for pharmacists, in that we were able to provide a convenient, cost-effective, therapeutically effective, maybe even superior mode of care during a public health crisis. I think something that's really flipped in the last 2 years, maybe even the last 9 months, is that rather than a public health driven, the words public health, CDC, socially vulnerable index, was a CDC term, and now CDC is somewhat persona non grata. It's much more, rather than public health, we talk about the marketplace driven needs. Marketplace versus public health. Foundationally, though, there's still a lot of similarities. It's what the consumer wants, what the consumer needs, and filling primary care gaps. I think all of those things are the same, but I think how we get to pharmacists providing these primary care services, we have to think about it much more from a marketplace, a business standpoint, not to the exclusion of public health, but rather than public health as the primary driver, the marketplace as the primary driver. I think another big change in the last 2 years, again in the last year, is the pharmacist role with vaccines, and really the role of vaccines. I think that's been, there's a lot more questions around that. We're hearing this year that the pre-orders for vaccines are down double digits, and that's for flu. That's not for COVID. That's for flu. So there is an impact on some of the services that we're providing, and there's other things that have changed, and I could go on, but I won't, because I want to allow my colleagues to have plenty of time as well. But the thing I'll finish on for this question is another big change, and I think an opportunity for pharmacists, is the growth of AI. I mean, can't get into any conversation without talking about AI. In fact, we're 16 minutes into this, and this is the first time AI has been brought up. So that's probably unusual for an NCPDP meeting. But AI, I think, not only is it a great tool, but it also introduces so much opportunity for bad information. I mean, so many hallucinations, or so many different things, where having someone, the pharmacist, as a source of truth, has that credibility, I think is going to be even more important going forward. I mean, people will use AI, they should use AI, but there's going to be more questions about this information. Is this information that I'm getting real? Is it right? Is it true? And I think if it doesn't happen right away, it will happen, where good old-fashioned people, humans, are going to be asked, what is the correct answer? What is the source of truth? What is right? AI told me this. Is this right? And so I think that's going to be, I'm not sure how that becomes marketed, monetized, put into the care plan, but I do think it's a big part of what pharmacists will be delivering now and in the future. And with that, I'll pause. Again, there's lots more to say, but I want to give a chance for my colleagues because I'm sure they have lots to add as well.
Great comments, Doug. And we'll move on to Michael Hogue at APhA.
It's hard to believe that it's been 2 years. Honestly, I thought when you said the call was 2 years ago, I thought we had mislooked at your calendar. It seemed like it was just last month. So I think the one thing that's changed in 2 years is time has changed. I mean, it's like everything moves at lightning speed nowadays. And I probably would have said the same thing 2 years ago, but how fast change is hitting us now. It really is mind-boggling, and it's as if every day there's something new that we're trying to adapt to or change with, and that's certainly different. I think over the last 2 years, one of the things we've seen some tremendous progress in state scope of practice laws, and I think that's one of the big successes that we should look back on and say, hey, this really is great. I mean, all 50 states now, pharmacists can engage in collaborative practice agreements with physicians. And, I don't think we could say that 2 years ago. I think we can say now that an increasing number of states have passed laws that require payment and non-ERISA plans to cover pharmacist services. Some of them have those coverages at payment parity, meaning that it has to be at the same rate that the physician's paid. So that's progress that's been made in the right direction. We have 3 states that have moved to a standard of care regulation in the state, which means that rather than listing out all the things a pharmacist can and can't do under the state law, they've adopted a standard that says the Board of Pharmacy determines what the standard of care is for standard of practice is for the pharmacists in the state based on your practice setting and your service set, and that's what you're expected to provide. So, I mean, I think those are lots of changes. Those are wins. I think we have, tremendous opportunity. In the last 2 years, the other thing that's changed in our world, and I think it's important to talk about the globe, is that Canadian government has recognized pharmacists as primary care providers. We have several provinces in Canada that have incorporated pharmacist payment for services as part of the federal government's, part of the state or provincial government's payment scheme. And pharmacists are providing large numbers of primary care visits to patients who otherwise would have never had access to care in places like Nova Scotia and Alberta and other provinces as well. Great Britain has adopted a similar model where all pharmacists are recognized as prescribers, which is an interesting thing, which is a primary care role. But, you know, some of the differences there, and I think some of the headwinds that we see in front of us, the biggest one that I can see is just interoperability of data. And that's a big topic for NCPDP. I think it might be the most important topic that our profession needs to deal with in the next 2 years. I think that if we want to see pharmacists be able to successfully fulfill their professional role in providing care at the top of their training, regardless of what setting they're in, they have to be able to have access to the patient's medical record, and they have to be able to contribute to the patient's medical record, not just look at it, but also add to it. And they need to be able to refer patients to other healthcare providers who need to see that patient. Pharmacists could be the entry point for a lot of patients in the healthcare system, and we need more continuous loop communication. The challenge we have in the US that is not faced in Canada or Great Britain or some other countries that have this model is that we have more payers than we can count, and we have more complex systems in electronic medical record systems. You know, you've got one player that dominates the market in the EMR space, but you've got a lot of other players once you get past that one player. We've got to figure out ways to connect the pharmacy systems together with the medical records in a meaningful way, bidirectionally accessing healthcare. To me, it's the big, again, I think it might be access to that information. If you can provide the information in the back-end systems to support a pharmacist's care process, then you can facilitate the payment mechanisms that are necessary. And it's about structure and process. We've got bright people in their practices that if we had the back end solved, and then I think it would lead us down a better path. And so I hope we can continue to work with NCPDP and others to try to solve this problem.
Great comments and very appropriate, Michael. I appreciate your insight on those issues. Casey.
All right. One of my goals today, Steve, is for you not to utter the words "you're on mute." So I'm working that. You got one a week, and I don't want it to be today during this presentation.
Yeah.
Well, thanks for the comments, Doug and Michael. Of course, I agree with them all, and we're all aligned with and working with each other on a lot of these important areas. You know, this notion of empowering pharmacists to provide clinical services in general, and the mechanisms to do that. But, you know, Michael pointed out, you know, commensurate with their training and the standard of care. And I hope that's something that comes up in the conversation going forward, and, you know, some of the questions that we have from some of the attendees today, because I think that's the new concept, you know, in our profession, and not just new and kind of in a shiny sort of way, but, you know, really important. And I think one that, you know, could really help facilitate us getting to that next level in terms of leveraging, you know, as Michael pointed out, the expansion of scope of practice at the state levels, you know, getting away from, you know, kind of long lists of things that you can do, and then, you know, trying to find in between there the things that they say that they don't say you can do, you know, and leveraging those, but really, you know, more with consistent with our training, clinical judgment, you know, differences sometimes in settings and credentialing and privileging and things like that. So I hope that's a conversation that we'll delve into. And I think a few years ago, we weren't probably talking about that here as much, but it seems like the new and an important thing. Yeah, I probably mentioned a few years ago, Steve, just recognizing pharmacists as providers, you know, as I think all of us agree, that's, you know, by and large happened across, you know, payers in terms of just technically recognizing pharmacists as providers. We've used this term provider status a lot, and when we were having our pre-call for this, we kind of talked about in terms of, it's really about payment. And, when we talk about provider status, naturally, we're talking about having pharmacists participate in Part B of the Medicare program and getting paid for, a defined set of services that are within their scope of practice and standard of care. That's still a really big priority for us, in Medicare, but it has been for a long time in Medicaid. Probably a lot of opportunities, with cuts to Medicaid that are happening to utilize pharmacists and a lot of others as a scarce resource to provide the care that so many patients don't have access to. We can get into a lot of like the technicalities of different payment mechanisms, and we can certainly all do that. The well-being of the pharmacy workforce, I know I probably mentioned that as did the rest of us a few years ago. It's still a challenge. We have real workforce challenges, both in our pharmacy and pharmacy technician workforce. Pleased to collaborate with everybody here on a recent summit on the workforce. Us and APhA and NABP helped organize that, but all the pharmacy organizations were big participants in a National Academy of Medicine first ever workshop on the pharmacy workforce. Getting it to that level was a big accomplishment. And having been around for 25 years, along with a lot of my colleagues, it took a while to get the NAM to recognize the value and importance that pharmacists bring, and the need to look at that workforce along with nursing and medicine, which has been a big focus. And hopefully we talk a bit more about that. I alluded to utilizing pharmacy technicians. This is a journey that we've been on for a long time, and trying to really position the pharmacy technicians at the right level to provide the level of care that they can provide to help facilitate all the important things pharmacists can do in the course of care. Doug didn't steal my thunder, but I don't suspect in 2023 that we brought up AI as a facilitator or a factor, but I think part of the conversation today, probably should be around, where we see at a different level AI, providing, a resource to us and an efficiency to us. I've had a chance to play around with it a lot, and when you point it toward the vast, wild, whatever direction you want to point west of the internet, it provides some pretty weird stuff. When you point it at really good data, like a good credible drug information database, or a source of clinical knowledge that you might have in an electronic health record in a hospital and health system where you have really good data, it does some pretty amazing things and creates some real efficiencies. And I think will and is empowering pharmacists to be more efficient in their work, and not replace what we do. There'll probably be some things that get replaced and some efficiencies, but I think Doug kind of pointed out, if you get 80% of what you need, and then you use your clinical judgment to verify and validate what's being put before you by an AI model, that's really where that human judgment comes in. So I think there's some really cool applications there. I'm glad you brought it up, Doug, because Steve, I want to get invited 2 years from now if I'm still around, and and be able to come back and kind of reflect on what we discussed around artificial intelligence in particular. But
Great.
those are my comments to kick it off, Steve.
Yeah, that makes perfect sense. I remember attending one of your meetings maybe a year or so ago, and the comment was made, and you know what I'm going to say. It says that no, pharmacists won't be replaced by AI, but pharmacists who utilize AI will likely replace those who do not. And so I think that may ultimately be where we land on this issue. So thanks again for those comments. Chad.
Yes.
Long-term care.
There you go. Well, I don't have the perspective to say where the conversation was in 2023. Certainly, I enjoy going last so I can get the perspectives of my colleagues, and certainly agree with all the things that they said with respect to where pharmacy is today and even where it was in 2023. One thing I will say, coming from the long-term care space, the older adult space, is that the change that has been occurring that we've been watching isn't necessarily fast. It's more like I'm trying to come up with a good analogy, but it's more like when it starts to storm and the big drops are coming down, but they're not quite coming down yet, but you know what's coming. And I think our approach to older adults in this country has been the same. You know, when I came to ASCP in 2018, it was because I was working in long-term care. I could see to some degree that our healthcare system was not ready to take the onslaught of older adults that were coming. And I also could see that the only discipline that was going to be able to help that onslaught was the pharmacist. Because again, you know, as I mentioned in my opening comments, this intersection of medication use in older adults is the busiest intersection in healthcare. And I think that's what's starting to happen. And it's happening in a lot of ways that, again, my colleagues talked about, particularly like from the caregiving perspective. We're having many more conversations. A lot of us, probably all of us, are involved at some level of recognizing a mom, a dad, a grandma, a grandfather that is dealing with healthcare and dealing with medications. And I don't know that we're always dealing with it from the perspective that isn't healthcare great? I think we're usually dealing with it like, how do we help people navigate this thing that is healthcare, and how do we make it easier, and how do we help people make decisions around what they should be doing with respect to their healthcare, and in our particular space, with respect to their medications. And I think that's really starting to come into focus as a driver of healthcare to the benefit, again, of pharmacists. This is what we do. We're on the front lines, whether you're in a hospital, a long-term care facility, the community, wherever you reside as a pharmacist, you are at the point of attack for healthcare. And if we aren't doing a good job making sure that we're laying the groundwork, that the public isn't acknowledging pharmacists, that payers and systems aren't acknowledging the role that pharmacists are playing, then we're not preparing those pharmacists for what's coming. I often talk about numbers, and sometimes I think those numbers, there's fatigue with hearing about how old the United States is becoming. But when you're going from 59 million people over the age of 65 today to 75 million by 2030, that is a substantial shift in population. And it's going to take all of our resources to make sure that pharmacists are there, are ready, and are capable in terms of how they're used by healthcare to perform services that help people. So you'll see us at ASCP working on things that, like age-friendly, is something that we've done in the last 3 years, working with an outside foundation that's just focused on aging and healthcare, that said, we want to acknowledge that pharmacists are age-friendly, and that means something to the public, and that the functions that they're performing may be as broad as how you package your medication. They may be as specific as changing from one therapy to another to fit what's important to you as a patient. And I think the more that those conversations come up organically, and the more that we drive them, the more the pharmacist finds themselves at a central role in healthcare. And I think that's what we're up here to do.
Great comments, Chad. And I think you're spot on in terms of, there's plenty of research out there that suggests that we have room for plenty of improvement in our current healthcare system. And if pharmacists can leverage their accessibility, their relationship with patients, and frankly their training. A lot of people among our membership, an increasing number, are coming to us saying, we think that's maybe a key to fixing a good part of what's broken in our system today. And if that's true, then an organization like NCPDP can focus its attention on something that Michael mentioned earlier, and that is getting easy access by the pharmacists to the information they need to do that work, and to be able to share it with the other members of the healthcare team for the betterment of patient care. So you got it. We're done. No. Question number 2. Thank you, Chad. Also a follow-up question. And we'll start with Michael on this one. It says, how how have your top strategic initiatives, and we in NCPDP, we refer to our priorities as strategic initiatives. You may call it something different. And relative to optimizing the role of pharmacists, how have they progressed since we met in 2023? Are they still in place today? Is it sort of more of the same, or are there new ones that you consider need to be added? And I'll begin the discussion and response from Michael Hogue at APhA.
Well, first of all, from just a structure standpoint, APhA has a 3-year strategic planning cycle, and we adopted a new strategic plan in 2023. So we're still under that plan. So I will just, in case one of my board members is listening, I have put our strategic plan out there, so now that you know that I know it. I'll just mention a couple things, and some of it is a little bit of a follow-up on what my colleague said in the answer to the previous question. We talked a lot about progress and opportunity, but I really want to talk about a place where we have failed, and pharmacy has failed, and the system has failed. And this is going to really date me a bit, but I think most all of us will recall that Bootman and colleagues did a study many years ago that showed that for every dollar we spent on drugs in the United States, we spent $1 on drug-related problems. You all remember that study, I'm sure. And then in 2017, a researcher from UCSF, Jonathan Watanabe, did the same study, repeated the same study, and discovered at that point in 2017, for every dollar we spent on drugs, we spent $1.55 correcting drug-related problems, meaning that the cost of drug-related problems have gone up and not down. And we all know what's happened to the cost of drugs. I was just looking at the 2023, which is most recent data that's available on the amount of money we spent on drug therapy in the United States. And it went up by $45 billion in 2023 over 2022, $45 billion increase in drug therapy costs. I'm going to guess, and I've reached out to Watanabe to ask him what it would take to get this study done and updated in today's dollars. By the way, I'll be contacting all of you for contribution to that study. And he said that he anticipates the dollar figure will be significantly higher. So if you stop and think about the way that our current administration thinks about problems, we have got a drug therapy problem in America that needs to be solved by someone. And I would argue, and I think all of us would argue, that the person who's most well qualified to solve drug therapy problems on the healthcare team is a pharmacist. But our systems and our structure and our infrastructure in which pharmacists find themselves working do not support pharmacists being able to focus on solving drug therapy problems. Increasingly, it's focused on the wrong things. The incentives are misaligned in our system, and the system does not support, particularly for our pharmacists in the chain pharmacy setting. They're not getting the support that they need to be able to spend their time solving drug therapy problems. And I could give you multiple illustrations of opportunities, but it's not an uncommon occurrence in a pharmacist day for there to be dozens of drug issues that need to be resolved, but the pharmacist does not have time to focus on it, nor do they get reimbursed for it either. They don't get reimbursed or paid for that. And I think everybody thought back in 2003 that the Medicare Modernization Act and MTM was the solution to that, and it's not. That's not it. How MTM was rolled out and how it was implemented is simply an administrative fee inside of the prescription drug benefit. And that was an abject failure, in my opinion, in terms of engaging and improving the opportunity for pharmacists to be able to solve drug therapy problems. We have got to have a drug therapy management benefit that is incorporated into major medical insurance where pharmacists are paid just like any other healthcare provider under the major medical plans. And is there a role for the, what I would say has become the traditional MTM as a part of the drug benefit? Well, probably, yeah, there's probably still a role for that more transactional one-off kind of engagement. But where we really have the opportunity is for pharmacists to be fully integrated into the medical team and to be paid as such. And I'd say that if APHA's goals or objectives or priorities have changed in any way, it's that we really feel like we have got to accelerate the adoption of pharmacists as a part of the major medical benefit and to facilitate the credentialing of pharmacists in that benefit, to facilitate the payment, to help with the back-end systems. I mean, we are so happy to get to partner with CPSN and NCPA on trying to figure those things out on the community side. And we partner with NACDS and the chain drugstores to figure out how we get this done. I think it's really critical. We have got to create the environment because we're losing pharmacies at too large of a rate right now. So if we lose all these access points to care, then how are we going to be able to deliver on the promise and the hope of what it is that Chad's talking about, which is a hugely increased demand? The demand is going to just sharply go up over the next few years for our services. And we don't have a system right now behind the pharmacists. So I'm hopeful AI will come in. I'm hopeful adoption of technologies will be taken up freely in our profession. I can tell you that I get hate mail at APHA from pharmacists who think because I advocate for automation, I'm taking away their jobs. And, I hate it, but if the only thing you do is count pills and put them in a bottle, then you probably aren't going to have a job. I mean, we do have robotics that can take that position, but we need your brain. We need you to actually do that part. And if we had a system that supported that, then it would be great. But our payment system currently doesn't support what I'm saying. And so I don't know. I'm hoping that maybe some of your listeners today are in positions where they can advocate within their organizations for a change in the way pharmacists are recognized in the system, for mechanisms to facilitate payment, for partnerships with community-based pharmacies and outpatient pharmacies to be able to have that facilitated interchange of data, but also, ease of billing structures, making sure that we can, end-to-end manage the patient from a revenue cycle. I mean, there's just so much that needs to be done on the pharmacy side. I'm hopeful it can be done. There's enough brain power to do it. There's enough technology to do it, but we've got to get the profession focused on putting pharmacists in that position. And I might be a little too passionate about the issue, but that's what I think is our number one focus right now.
We can hear it in your voice, Michael. Well stated. Casey.
Can you repeat the question, Steve?
Yeah.
It's a great answer Michael gave. I think it was.
I think it was. It was. Yeah. Really just, strategic initiatives or priorities of your
the priorities have changed.
Yeah.
Yeah, and the pretty consistent priorities. Actually, our board just approved a new strategic plan that's going to be going out here in a couple of weeks. A lot of consistency with the previous plan. Some areas of that we've already identified, areas like AI and the use of automation. The whole point that Michael brought up about just sort of the addressing, the affordability of healthcare, quality issues in healthcare. We talk about medications a lot, but all the drug development, in the recent past and the future are in things that we probably don't even call drugs, cell and gene therapies, and a lot of, really high cost, but really effective, some for more narrow therapeutic uses than others that are, we're going to be faced with, either handling, administering, providing clinical judgment around, or somebody else's in some cases, because again, there's gray areas in the definitions of where, some of these really impressive breakthroughs in therapy are coming from in the cell gene area. And the term high cost gets affixed on there a lot. And I think, it's not just kind of carving out our niche, so that we're not, disintermediated, by another segment of healthcare providers or a new one. But, kind of getting back to Michael's point, making sure that, drugs that cost hundreds of thousands of dollars, sometimes millions, are used effectively and for the right people in the right ways at the right time. And we get, the patient care benefit and societal benefit out of those. And there's just no question that pharmacists are and will be the best position to do that. But, it's a evolving area and rapidly so. And I don't, view it as like a territorial thing, that these are all kind of team activities in healthcare, or they should be anyway. But, kind of standing up as the people that kind of spend the most time, not just training and being educated, but thinking about and really kind of handling, the circumstances in the most effective ways. And I think we have a lot of opportunity to innovate and kind of lead in that area. We talked earlier, and you think about evolving areas, sort of expanding scope of practice, access to the patient care service as a pharmacist. Sort of tactically, there's definitely a shift to the states, and that's not a shift away from, national policy issues like, I'm going to use the term provider status, but amending the Social Security Act to recognize pharmacists as Part B providers, that's got to remain a focus. All of us that have worked in Washington for a long time, we're not complacent or like the status quo. We're super impatient with the status quo, but they just move a little slower here in the Washington D.C. area, and for some good reasons, for some not so great reasons. It happens that way, but you got to stay at it. You just can't kind of park these big issues like provider status. It's easy to look back and go, geez, this has been going on for, I don't want to say approaching, two decades, but probably approaching that. But if you kind of look at the incremental progress that's been made, the level of understanding that policymakers have of the issues, why they're important, why pharmacists can play a role. Again, I've worked in our kind of public policy area for my entire career, and the understanding's deeper, the support is greater, and these things at the national level will reach the appropriate point. Hopefully they don't reach crisis level, because that's often times when things actually move. But I can say, and I probably speak for everybody here, that all of us here have a plan. If God forbid that crisis comes, to plug in and meet the needs of patients. But certainly at the states, that they need the support of everybody that could possibly provide a service. I mean, whether it's PAs, nurse practitioners, there are not enough physicians out there to provide the primary care that's needed to be provided. There hasn't been for a long time, and I think we've had some really credible cases. But I think just the necessity is growing to improve access to care. And to Michael's point, everybody's on a drug, and drug therapy isn't optimal. It's not as cost effective as it can be. It's not as safe as it can be. The quality issues. And I think pharmacists will have real opportunities over I don't know what the span of time is, but today certainly, over addressing and opportunities at the state level. I was pleased to hear from a member of Michael's team on pharmacy profiles, the great work they're doing to better connect, probably community pharmacists right now with payers, and to get them credentialed and privileged so that they can actually do some of the things that state empowers. And I compliment you, Michael, for the work your team's doing there on profiles and that. And I think that has a real opportunity to net some real positive benefits down the road. But those are kind of just high level, Steve. Clearly any of us could talk probably until we fell asleep doing it on any of these topics. But I'll stop there.
Okay. Well done, Casey. And I do think you represent a great potential laboratory for these nuances that are coming along. When you operate under a P&T function, for example, you get some pretty easy acceptance under arrangement. So you can help all of us by moving forward and on those fronts.
I think being able to
Chad.
replicate that model too, we talk about in the hospital and health system, we have a closed environment, access to the health record, but Michael earlier was talking about interoperability, sharing data,
Yes.
connection. And I think that's kind of the secret ingredient there, access to the team, access to the information, and then kind of that central body that, could credential and privilege pharmacists. And hopefully we can have that across the spectrum. I would hope in the next,
Yes.
I don't want to say decade, because I may not be maybe sitting on a mountain in Colorado where you are, Steve, by then.
Yeah. We should do that together sometime. Great. Chad, give us your thoughts.
Well, I go back, we have a strategic plan actually gets, we work on it this upcoming year in 2026, but it's really three areas. It's engagement, empowerment, and expansion of pharmacy practice. So the things that we continue to prioritize are, we want to be delivering good clinical education opportunities, whether they're on the policy side or the practice side, and resources to our members so that they can continue to practice at every aspect of pharmacy where there's opportunity for them. We also empower them through that process. But we're trying to get some acknowledgement. Again, I bring up the age-friendly component. There are hospitals and clinics that the Institute for Healthcare Innovation credentials as age-friendly. We're now able to credential a pharmacist as age-friendly. And it's really not a credential. I shouldn't use that term. It's an acknowledgement. I mean, for 50 years, ASCP has been around, and the pharmacists that work with older adults in nursing homes and assisted living and in the community, they are age-friendly by nature of what they do every day. But giving them that acknowledgement and having that language that the John A. Hartford Foundation has established in age-friendly creates the public perception of the pharmacist as age-friendly, and therefore a trusted local resource to go to get information. So we're focused heavily on that. We are developing that same acknowledgement for pharmacies to be considered age-friendly. So again, that public has that recognition that there's a place to go if I need help with my mom or dad or my grandma or grandfather. I need help with myself. I'm reminded every day of watching my dad lay in his lazy boy chair with his MedMinder on his chest, with his giant hands trying to put his medications in his weekly MedMinder, and thinking the only reason he has to do that is because his insurance provider won't pay for the compliance packaging services that some pharmacies are willing to do, but cost more money. So how is that helping our patients, and what can we be doing to make sure that pharmacies and pharmacists have the ability to get reimbursed for a lot of those services? And I'm kind of excited at the rotation because I get to go ahead of Doug and say that our priorities are 100% reimbursement, reimbursement, reimbursement. And it's not just reimbursement for clinical services or things that we might associate with provider status. It certainly is, but it's also appropriate reimbursement for pharmacy services that aren't specifically limited to those clinical or cognitive activities. It's, do you package your medication? How do you package it? How do you provide service? Do you deliver? Is it 24/7 access? The kinds of things that older adults may require in different settings needs to be reimbursed. That's not sort of a standard reimbursement that you get from payers. So we're working on reimbursement as a priority across all aspects of pharmacy to try to improve those opportunities for our pharmacists.
Great, Chad. Doug, last but not least, Doug Hoey.
Yeah, thanks, Steve. And yeah, no, it's kind of a challenge and a pleasure to go last because everyone's had such great comments. And as Chad said, the reimburse. So NCPA's strategic or overall strategic goal is to change the pharmacy payment model. And that was true in 2023. It's actually true in 2021. It's true in 2019 to change the pharmacy payment model. And again, Chad said it well that when we say change the pharmacy payment model, we're not just talking about dispensing. We're not just talking about clinical services. We're talking about both. And actually, we're including consumers in that too, because for consumers, patients, they have no idea most of the time what they're going to pay when they walk into a pharmacy or when that primary care provider writes that prescription for them. It's like a trip to Las Vegas. I mean, are they going to lose it all on the table, or is it going to be an inexpensive medication that works great for them. So we do have a new strategic plan, but again, that overarching that we just approved, our board just approved a few months ago, about 3 months ago. But the overarching is still changing the pharmacy payment model. I think in the last couple of years, some of the differences that are occurring and have occurred. One is the importance of paying pharmacies fairly for dispensing. And I know we're here to talk about clinical services, but we believe you can't have one without the other. That you have to have that stable base of it's still the economic engine of almost all community pharmacies. The economic engine is still the dispensing of medication. And that has to be stabilized. It is completely unstable right now. We've seen since 2017, 10% of all there's been a 10% contraction of the number of pharmacies in the United States. And that's not counting the 1,200 Rite Aids that just went bankrupt. That's not counting the 600 Walgreens that when Sycamore took them over, that they said they're going to close. I mean, we're looking at 15% contraction within the next year. So that's fewer places. That's expanding pharmacy deserts for access to medications. But if you want a flu shot, most of those pharmacies were providing flu shots. There's going to be also pharmacy deserts for some of the primary care services that we're talking about. So that stability is incredibly important. And that's something that, through legislation, because 2/3 of all the prescriptions in the United States are paid for by Medicare and Medicaid. So we are interested in stabilization of that. Two other quick things. One of the places, and we're almost an hour into this, and another acronym that hasn't been said yet is the word PBM. PBM are probably the biggest anchor around the transformation of pharmacists providing care. Certainly the stabilization on the dispensing side. PBMs are the nemesis of that and are putting pharmacies out of business. As a result, pharmacies can't provide those clinical services. And we've seen some pretty weak efforts from PBMs to pay pharmacies for clinical services. They're a lot of cosmetic, but not really meaningful. And so I think one big disappointment that I've seen is the vertical integration. When the PBM started to vertically integrate with the health insurance plans, I personally actually thought there could be some hope there because the health insurance plans want to lower, well, you'd think would want to lower overall healthcare costs. And rather than just, the more expensive drugs that are dispensed by PBMs, the bigger the rebates, there was hope that there would be a desire to actually manage overall healthcare costs. But unfortunately, we haven't seen that. The drive to increase drug costs to get a bigger rebate seems to have eclipsed that desire for lower healthcare costs. But still, I have hope that sanity will prevail and those lower healthcare costs, pharmacists will be rewarded for that because they can do that. The last thing I say, and this is consistent with what I just said, so CPSN, the clinically integrated network, we think it's the right thing at the right time. I just got a stat sheet that was forwarded to me last week. There's been one of their pilots or one of their networks resulted in a 30% reduction in overall inpatient hospitalization costs with MCO members utilizing CPSN pharmacies. So 30% reduction in inpatient hospital costs when using a network of outpatient clinically integrated pharmacies. So if that desire is there to lower overall healthcare costs, it's yet another proven fact where pharmacists can deliver there. So I'm optimistic we're going to get there. We just might have to have a lot of, there might be a lot of failures before we get there, but I'm optimistic that we will get to this envisioned future where pharmacists are helping to lower overall healthcare costs and not just stuck in a silo like, to Michael's point, MTM did 20 years ago.
Well stated, Doug. And we're going to move quickly to question number 3, and we'll have Casey lead this one off. And the question is, organized pharmacy, and when I mention organized pharmacy, I'm essentially referencing the members of JCPP, the Joint Commission for Pharmacy Practitioners, that 11 or 12 member group. I can't keep up with how many national organizations are members. More, 14 maybe, something like that. Anyway, that's who I'm referencing as organized pharmacy. And they have really been unified in their efforts to attain provider status. What, in your opinion, will be the tipping point in making this a reality? And we'll ask Casey to lead it off because I know he's been intimately involved in that effort from the beginning.
Well, we're all part of the same coalition, so I hope we have the same answer, but I'm sure we'll say it differently. But no, there's great unity, and there has been for a long time from the vast majority of those groups on that issue. It goes without saying that there's no new money that goes into the Medicare program. This is a cost neutral program. So, if you take, put money here, you have to take it from somewhere else. And, that engenders opposition from time to time from various groups, organized medicine and others. I think everybody on this Zoom today has members that work very closely with physicians, that those physicians value them, vastly to no end, in almost every setting of care. But the issue of payment is a real issue when you have a program that's built to be cost neutral. That can be a real challenge, because everybody's stretched. Everybody has to make a living. Everyone wants a raise, and everyone needs to preserve kind of that facet of their part of the program, and there's a lot of threats to it. And as you know, the federal government's focus has been more on reining in spending. So that presents challenges, and that's getting back to the opportunities at states. Medicaid arguably still a federal program funding wise, but the states have to administer it and figure out how to make it work. And I believe that's where a lot of the opportunities reside. The environment and time will come. We leveraged it during COVID to expand what pharmacists can do. Pared down a version of our bill to hone in on some of those areas because there was proof, by nature of what happened in the pandemic around sort of test to treat areas that really provided benefit. And it's frustrating, when as Michael and others pointed out to, when that evidence is there that the investment doesn't always follow, and which would mean payment that to Michael's point would prevent a lot of drug related problems, provide better access to care, better quality of care, but it's still a fee for service environment. So I'll sum up my point, and this is, I don't know, I don't think it's an excuse, but we've been talking about value-based payment for a long time, and we're moving closer to that model. The program, meaning Medicare, is still a fee-for-service based program, even with value-based built on top of it. But I think as we evolve further, to paying for outcomes and incentivizing organizations, providers, and teams in that way, it'll make it a lot easier. And then we don't have time to get into targeted areas. We talked about Medicare Advantage and utilizing that, and then Medicare Advantage plans having a whatever version of CMM, MTM you want to provide there. Trying to leverage some of those things to provide. I don't think we need more evidence, but provide more evidence. To where it's a lot more obvious to make those changes in the Social Security Act at the national level.
Great, Casey. Chad, we'll let you go second.
Thank you. I think, first of all, I think the members of JCPP, a lot of the Pharmacy Association members have been very unified in our approach to provider. We've really rallied around ECAPs, coming out of COVID, recognizing the role pharmacists played, really rallied around the idea that we could get this done, even if it was the foot in the door of future expansion of what, being mentioned as a provider in the Social Security Act means to the profession. By that same token, I'll also tell you that when I graduated with my BS in pharmacy in 1996, we were talking about provider status, and it's 29 years later. So we definitely could still use an uptick And I think it is at the organization level to be a little bit more emphatic. Um, I love what Doug had to say about the clinically integrated networks and how they're producing data that is helpful to health systems. I think if we emphasized amongst our organizations more the need to really come together. We have a deal-making administration right now, and not that that's a good thing or a bad thing, but there's an opportunity to have that conversation on how pharmacy saves healthcare, in particular Medicare and Medicaid money. We have state programs that can demonstrate that. Again, some of the CPESN data can demonstrate that. We have historical research that demonstrates that. We ought to be able to push the ball forward. It will take an unbelievable commitment from all of us, but I feel like we're in the right space in our conversations. We meet every week, well, now it's every other week on Thursday as professional associations talking about things like provider status and the big needle movement things that are going on in our profession of pharmacy. And if we can maintain the focus that we're here for the profession of pharmacy and pharmacists and put some of our individual priorities aside to move the whole profession forward, I think we can get there in relatively short order.
Great, Chad. Doug.
Yeah, thank you, Steve. Really just to add to what Casey and Chad have covered. I obviously I believe we will get there as far as provider status. It just makes too much sense not to get there. It is, as Chad said, 96. I think, yeah, even longer than that. It's been going on as far as provider status. But I think a couple of new ways we'll get there. One is through the marketplace. Again, especially this administration, but I think a marketplace driven where we're making the case, showing where pharmacists make more sense, or not, where they make sense to be filling some of these primary care gaps. I think as those gaps increase because of primary care provider shortages, there will be some logic. Again, the marketplace will say who can help in a cost-effective way fill these gaps. And I also agree with Chad that we organized pharmacy need to be louder, or need to continue to be loud with making that point. I guess one new thing I'll throw into the conversation, pharmacy, even though we've made tremendous strides as a profession from beyond, counting pills and being viewed as counting pills by the public, by legislators, we still have a long way to go. I was in a conversation with someone who represents a lot of employers just a couple weeks ago, and talking about, hey, let's talk about how pharmacists can help provide services to help your employer group save money. And he wasn't trying to be rude or mean, but just gave me a sharp dose of reality, which was, you guys are viewed as dispensers, and you also give shots. And I didn't like hearing that, but I'd rather hear if that's the reality, so we can work on it and try to fix that. It's not a small issue to change your public perception, but I think it is happening, and I think there are things that we can do to help put more fuel on the fire to accelerate that change in the public perception of pharmacists.
Great comments, Doug, again, as usual. Michael, you're last, and you're last for a reason, because of your efforts on the credentialing front, as well as recognizing and mentioning earlier all the progress that's occurring at the state level. So regarding provider status. So you're hitting cleanup today, Michael.
Okay. Well, let me just talk broadly about organized pharmacy. And, I think our profession's probably not unique in this space, but whether we want to admit it or not, the vast majority of pharmacists in America are not a member of any professional association. They're not a member of any of our associations or any other associations. And you asked me to back that up with evidence, and I'll tell you, I can't accept that I talk to an awful lot of pharmacists who are not members of anything, and it's not out of intention. It's, I think, out of not understanding the value that professional associations provide to their day-to-day life. And I'm going to make a point with this story that I'm going to tell, but it's going to seem like I'm taking us off point for here just a moment ago. A wise mentor of mine once told me that you get paid in life based upon the complexity of the problems that you solve in life, which is why a brain surgeon, a neurosurgeon, gets paid significantly more than a family practice physician. The complexity of the problem is much more difficult, and so therefore that individual gets paid more. If you look at the salary tables in pharmacy by specialty, and I know this having been in a health system just prior to coming to APhA, the oncology pharmacy specialists actually made more money than the staff pharmacists inside the hospital, because they are solving more complex problems, perhaps. I don't know if that's right, wrong, or indifferent, if it should be that way or not. But what that illustrates to me is that we have to be good in organized pharmacy at actually solving people's problems or helping them solve their problems, if we expect that people are going to invest in us and leverage the value that professional associations provide. You know, lots of good work has been done at the state level by state pharmacy associations on shoestring budgets, because many of them have very little staff, if any, to be able to accomplish the work that they're doing at the state level. But with the support of the national organizations and grassroots advocacy by pharmacists and local communities, they've been able to make change happen. And we have to be able to get pharmacists to do the same thing at the national level. We have to have that grassroots advocacy applied to the national level in order to be able to accomplish things. So I just, I guess what I'm opining on is not so much about the national associations and our priorities and so forth and what we've done that makes a difference, but just to say that regardless of where a pharmacist is in the system, every pharmacist really needs to be plugged in and involved. And, a lot of time, I had a pharmacist that recently told me, because she had gone to work for one of the large pharma companies, that she had left the profession and gone to work for a pharma company. I said, "What do you mean you left the profession? Do you not renew your pharmacy license anymore?" "Well, no, I still do that." I said, "You're still a pharmacist. You're still a part of our profession. You just are utilizing your knowledge, skills, and ability and applying it to the pharmaceutical manufacturing process. You're at an earlier stage in the patient care continuum than what your frontline colleagues are doing when they're taking care of patients, but you're still a pharmacist. You're still a part of the profession." I don't know how we got to this point where pharmacists in insurance companies didn't see themselves as a part of the profession, and where pharmacists in industry didn't see themselves as a part of the profession, but we've made that mistake. And I think we need to leverage all pharmacists across the entire profession toward this common goal of ensuring that consumers have access to the care services of pharmacists anywhere they interact with the healthcare system. And so we've got to have pharmacists and health plans helping us get pharmacists credentialed, so that the frontline pharmacists and community-based pharmacies and ambulatory care clinics and other settings, long-term care facilities, so that they can get paid for the service. If we had more pharmacists in health plans and PBMs advocating for pharmacists to be onboarded as credential providers within the health plans, then this would be happening faster. So we need our colleagues to do that. You mentioned pharmacy profiles. I'll mention it just one last time. APhA took on the challenge of creating a platform. So most of you know that for physicians that get credentialed by a health plan, in order to be credentialed in a health plan, the majority of health plans utilize an organization called CAQH to do that credentialing. And CAQH was actually created by 10 large health plans that wanted to have a common method for being able to credential physicians, and that's where CAQH was born. the profession of pharmacy indicated back in 2017 that it wanted to have a profession-centric one source of credentialing in pharmacy so that we could, not have 10 different ways to get credentialed, much like physicians have a way primarily through CAQH, that there would be an A way to do that for pharmacists. So the APhA board invested in a software solution that would allow for that to happen called Pharmacy Profiles. And we have been working diligently with lots of partners to get that system up and to get it recognized. And it's now NCQA accredited, which allows health plans to be able to recognize, and it also allows CMS to be able to recognize it as a credentialing organization, credentials verification organization. And then we're working diligently with various health plans to get them to utilize the platform of Pharmacy Profiles to expedite onboarding of pharmacists into their systems. And so that's what Pharmacy Profiles is all about. It is owned by APhA, but we partner with NABP, with ACPE. We are partnering now and working with NCPDP, and we're trying to make this happen as quickly as possible across the entire profession. And we've had great conversations with all of the folks that are in this room, with ASHP and NCPA and ASCP and all the other pharmacy organizations about how, we may not have it perfect, help us get it better, get us on the right track. Let's make sure that we're supporting pharmacists being able to get there. Ultimately, our goal is to get pharmacists paid and get them credentialed. And this is one of the ways that APhA is trying to help facilitate that, trying to help get it there. And by the way, lest there be a cynic on your phone call, no, APhA is not doing this as a money-making venture. In fact, it doesn't cost pharmacists a dime to get credentialed in Pharmacy Profiles. It's free for pharmacies or for pharmacists. It's intended to be something that the health plans utilize to help them with their processes and onboarding. So the cost burden comes to the health plans as they onboard these providers, pharmacist providers into their network. So I just want to be clear about that. We made an investment, and we made the investment because the profession needed the investment to be made. So
great explanation, Michael, and we appreciate your efforts in that space, certainly at NCPDP. We have one final question, and this is kind of in Chad's wheelhouse, and we're gonna let you do this one, and then we're gonna try to move as quickly to a couple of questions before our time is up here, if we possibly can, Chad. Question number 4. The next question is clearly in your wheelhouse for long-term care, but is relevant for pharmacists practicing in all patient settings. And the question is, what role should pharmacists play in transitions of care, and how can we standardize their contributions across settings? And Chad, what are you seeing in terms of progress being made now that more emphasis is being placed on pharmacists in that TOC space? And what does that mean for the long-term care setting? What obstacles are you still facing? We're going to let you run with this, Chad.
Sure, and I'll be brief to leave time for questions because I think we've talked a lot about the issues already throughout the presentation today. But I mean, I think the number one challenge is the interoperability challenge that was brought up earlier. In some ways, we recognize that pharmacists have become the central person that takes care of people as they transition from hospital to home, from hospital to long-term care setting. And there are pharmacists generally on either side of that relationship when they're going from the hospital to the nursing home. Even those pharmacists have evolved into that role, to take that role. And I'm actually doing a presentation with NTalk, which is the National Transitions of Care Coalition. And I'm doing it with one of the leaders from ASHP. And we're going to be talking about what that handoff looks like between that hospital pharmacist and that long-term care pharmacist. And what was funny about our conversation is we both lament in some ways the job the other pharmacists might be doing on either end of that handoff, and how that transitions of care handoff needs to be like a relay race handoff where the baton is placed in the hand of the pharmacist taking over the care of that person from the pharmacist that's been taking care of that person. And I've framed this in the transition from hospital back to home, from hospital to nursing home, from nursing home to home in our transitional patients on the long-term care side. But the reality is we're missing a major component, and that is the community pharmacist. And who is reaching out to that community pharmacist when someone falls at home and is admitted to the hospital with a hip fracture? Who's coordinating to see, well, what meds were they on? Maybe it was one of those meds that led to that fall. So we have an interoperability obstacle that still sort of lingers out there where community pharmacists aren't having the same access to the records as the hospital pharmacists are or the nursing home pharmacists are. We have some challenges in that the nursing home pharmacists have access to medical records that are of a certain long-term care system, and the hospital system has their own system, and the physicians and the people in community practice have their own system of medical records, and getting all of those systems to talk to each other. So I think that's the primary challenge. What I think is encouraging for pharmacists is that we've evolved into this role. We are the ones now that are responsible for coordinating a patient on their way out of the hospital. We're responsible to bringing them into the nursing home, and we're responsible in the community to bringing them back to their home setting and make sure that their medications have been appropriately assessed and adjudicated as they come back to that system. I think our biggest fear as long-term care pharmacists is we saw somebody go from home to hospital because of a med-related issue, and they get discharged either into our nursing home or back to home. And the first thing that happens when they get back to that community is they get put back on the drug that led to their original reasons for being hospitalized because it's unrecognized or because there's bad handoffs. So I think it's a natural place for pharmacists. It's a place that still continues to grow and has opportunity. And we just need to continue to focus on how we liaise between those different aspects of pharmacy and with those interoperability systems.
Great comments. I'm going to just open it up. Are there any other comments that individuals would like to make individually before we take a couple of questions from our audience?
I have one comment I'd like to make, Steve, that came up, and it's so current and such a current topic in today's environment that I feel like we'd be remiss not to mention it. And it's the move to direct to consumer that came from the president's executive order. I don't know how that's all going to shake out. I don't have a crystal ball that's quite that clear, but I will say this. Whatever we create in terms of a system for connecting pharmacists to electronic health records and compensating pharmacists for their care services, we have to imagine that it's possible that the pharmacist that provides those care services may not be the pharmacist that dispenses the drug. It might be, but it might not be. And right now, we don't have a system established that would actually allow a pharmacist who's not dispensing the drug to be able to connect in a meaningful way and bill for or document the care service that they might provide. So imagine, for example, a pharmaceutical manufacturer that uses two contracts to provide the dispensing of a certain medication. But the patient chooses that they want their local pharmacist to provide the care services around that drug and not be forced to have to use the care services of the mail service pharmacy. That's a reasonable assumption that a patient might make. So they might go to their local pharmacy. That local pharmacist should be able to provide those care services, and there should be wraparound compensation for the pharmacist to cover the care that that pharmacist provides, no matter where the patient gets the prescription dispensed. And so, that's another one of these things from a health policy standpoint and an infrastructure standpoint that we all need to be thinking about, is that the person providing the care service may or may not be the person dispensing the drug. While I think it's best that it be the person dispensing the drug, in many cases, it's not going to be, because the system is going to pay for drugs cheaply in some other manner. We don't know what that's going to be. So I would just advocate that we think about that we think about that it's not so easy in the system right now. If you're not the one dispensing the drug, how do you bill for that? And, you know, NCPDP's transactional standards might help facilitate that. But we still have to have a payer on the other end that's going to accept that and at a reasonable and pay for it at a reasonable rate. So there still has to be something on the other side that's done.
Okay, great. Other comments?
Yeah, I would just follow that up. I think it's a great comment, and we just had it. I just heard on the news this morning that one of the GLP-1s is opening a direct to consumer.
Yeah.
You know, for $500 or something, you can get your GLP-1 directly from, I think, Novo Nordisk. But I think those things end up driving exactly what Michael's talking about. We know that an individual is not going to get direct to consumer drugs from 10 different companies coming at 10 different times with 10 different ways of paying for them. That ultimately doesn't work. If you're a young person and the only thing you're taking is one of these medications, you're doing it for more cosmetic reasons than you are healthcare reasons, then sure, you can go pay cash for it somewhere. But I think at the end of the day, this kind of activity drives exactly what Michael's talking about, is there has to be some level of coordination at some point or some central hub for these direct-to-consumer models, and it all lands back at the foot of the pharmacist. So I think I just wanted to follow that up, that sometimes these things come out and people, it's the sky is falling again, and here's another example, but in some ways these things will drive exactly what we want and where we want to go as a profession.
Great, great.
Yeah, I'll add that DTC, it's, you know, it really will depend on what DTC means, because the White House executive order didn't define what direct to consumer means. So it could be the sky is falling, but I also think it's an opportunity to change the pharmacy payment model, where, you know, people I've talked to say this is an opportunity to right the addiction to rebates that has really kind of corrupted the whole system and made our drugs in the U.S. the highest costing drugs in the world. So it's not something that we are taking lightly. In fact, we're very concerned about it, but we're also concerned that it could be a great opportunity for pharmacy too, to really shake things up in a way that hasn't happened in pharmacy maybe ever.
Great, great. Well, listen, we are almost out of time. And I guess we did get a question from the audience, and we have several others listed here that we will not get to today. I'm going to generalize that question that we got from the audience and say to you all, ask the question, what can NCPDP do more of to help in this transition from, you know, just dispensing to providing essentially primary care services? And in that vein, are you interested in promoting, or how are you promoting the implementation of our efforts related to the S1, the service billing, S1 or S2 service billing transactions that would in fact presumably encourage more activity on the service side of the equation? I'll just open it up to whoever wants to answer in the 2 minutes we have left.
I think this will be fast. I think anything NCPDP can do and can do more of, because I think this is one of the things that NCPDP does, is to take friction out of the system from all the multilateral different ways between the payer and the payee, between the payer and the pharmacy, between the pharmacy and the patient. So I think through the standardization of codes and, you know, other tools that NCPDP has to provide that common denominator to take friction out. I think because as we adopt and we try to get more people interested in paying for pharmacist services, it needs to be as frictionless as possible. And I think that's a great service that NCPDP does and can do.
Okay, great.
I'd just add quickly to that I think One of the challenges that a lot of pharmacists have right now is that when we bill a drug claim, it's, you transmit the claim, you get, immediately what you're supposed to be getting paid, although that might change in 3 months, but it's supposed to be what it is. But, what we don't have the ability to do right now in pharmacies, because dispensing systems don't have this built in, and maybe NCPDP could help facilitate it, is the connectivity to the health plans to be able to at least determine eligibility, or to have someone determine eligibility, even if it's in advance. So my doctor's office can tell, because of my insurance, they just look it all up. I don't even have to provide my card anymore. They just look me up by my zip code, and sure enough, there he is, and here's his valid insurance, and they can verify. AI can take care of that. So if NCPDP could at least have the conversations with the vendors for pharmacies, community-based pharmacies, the chains, and others, how can we expedite that front end verification process of eligibility for medical claims? I think that may sound like something that's way off into the future, but I would tell you that the faster we can get that done, the better, because pharmacists are reluctant to provide something that they don't have.
Great.
They don't have verification is going to be covered.
Great. Any other comments? We're gonna pull the chain here on our session and let Pooja wind things up for us. So thank you again for your efforts. We really appreciate it.
Great. Thank you, everyone, so much. Great conversation. And I love the last comments about, how we could support this. And I agree. I think just everything with our new strategic plan and things that we're doing, and, having conversations with the health plans is really going to help. So thank you again to all our panelists. Thank you to all who joined us. Just a friendly reminder that you will receive a link to the webinar, the replay, within 5 business days. And just quickly before we go, we have other things happening around our education. Tomorrow we kick off actually a 3-part town hall series with HIMSS on pharmacy interoperability. So today we talked a lot about the, making sure that the pharmacist can access the patient record and write back to the patient record. And tomorrow's conversation at the HIMSS webinar is going to be all about that. And then we have a COB webinar on September 9th to dive into the next chapter of coordination of benefits. And finally, just ties into, again, the last comment that was made. We are going to do our Ed Summit this year, focused on improving quality through collaboration between health plans and pharmacy. So really excited about that. So look for more information coming in the future. And then finally, we just launched our call for proposals for our annual conference. It seems very early, but it comes fast and furious. So next May 4th through 8th. Registration's open, and we'd love for you to submit for proposals to talk about kind of all this stuff related to interoperability and connected care. So we welcome you to get to know NCPDP if you're not a member, and we have lots of work groups. We have lots of strategic initiatives going, and so we're always looking for new people and ideas. So with that, I want to wrap up our webinar. Thank you again to our panelists. I know you all are very, very busy, so really appreciate the 90 minutes that you took to spend with us this morning, and we look forward to our continued collaboration around this. So thank you so much, and have a great week.
Okay. Thanks all.
Thank you.